Thank you very much for being here. Thank you, Zubin Foundation, Croucher Foundation, and Lee Hyson Foundation for making this possible, and Eric for taking the lead in evaluating, because that's the key. Over the next half an hour, I'm going to talk about culture. When I first went to the UK, I remember having a conversation with my tutor. As trainees, we had tutors who looked after your well-being. And she advised me to watch Coronation Street, which is a soap opera on British television, been running for 50 plus years. And at that time, that was the only soap opera. And she said that if you really want to understand British culture, you must watch it. And I'm not sure that was, any soap opera is typical of any culture. But what it did do was that the following morning, if I was sitting in my outpatients clinic and seeing elderly individuals, you could test their memory and say, did you see Coronation Street last night? What happened? What it brought home to me was that we just assume that, minority groups have cultures. No, everybody has cultures. And I want to sort of keep coming back to that, because what do we mean by culture? The word comes from cultivation, agriculture. It comes from this process initially from moving things from agrarian societies to cities and states, and then large political entities. Mr. Smith is cultured. What does that mean? It means that civilized. Now, it worries me. Lots of things worry me, and as I grow older, you worry even more. And particularly when you know that you can't do anything about it. But what culture does, we're not born with a culture. Nobody is. We're born into a culture. The fact that, Durga was born in Nepal, and her upbringing there was very different. And then she has to come here and readjust what's going on. And three things that you need to bear in mind, particularly for migrant groups, are cultural bereavement, things that we've left behind, culture shock, where have I landed? How do people live in this small place? And culture conflict, which is very strongly linked with lots of psychiatric problems and with self-harm. And what you were describing about your experiences being depressed and being oldest son with certain expectations, with responsibilities, but it's also feeling trapped, that you can't move out, you can't go anywhere, you're just stuck. Culture is about collective identity. Who am I? And I'll keep coming back to that, because that is the crux. Basis of historical lineage, language, religion, gender, sexual orientation, ethnicity, etc. It's a way of life. We imbibe culture. Subconsciously, consciously, our parents tell us, you're letting us down if you don't do A, B, and C, whereas your neighbor is doing X, Y, and Z, and nobody questions that. Culture tells us how to bring children up. That affects our cognitive development, that affects our social development, that affects our emotional development, and that's how we look at the world in that particular way, the way the culture has trained us. And what it does is that it's socially transmitted. It gives us a series of things. And one of the things that we need to bear in mind is that individuals have cultures, yes, but institutions too have cultures. HKU is very different from Chinese University of Hong Kong or any other university in Hong Kong. How did that happen? Now, institutions are not buildings, they're people. And we learn from each other and we absorb each other's values. And those practices then cannot be reduced to simple models. So cultures are about unique behavior, unique lifestyle in specific settings, be they universities, hospitals, departments, institutions. But we need to bear in mind that cultures, by and large, are dynamic. Hong Kong of 50 years ago is not Hong Kong of today. India that I left in 1978, 79 is not the same now. And every time I go back, it shocks me. And then I get angry. How dare they move without me? And you look back and think, would I have felt exactly that had I stayed on? And what that does is that we have these kind of expectations of each other. It's a common heritage, a set of beliefs, norms, values, and shared meanings, which is the crux. What does culture do? Several things. It generates symptoms. When we are feeling distressed, culture tells us what that distress is, how we are going to express it, and where we are going to seek help from. It also allows us, or not, how do we manage our symptoms? And Professor Yap from Hong Kong University 60, 70 years ago talked about culture-bound syndromes. And there are some syndromes which are very specific to certain cultures, but not all. And I'll come back to that, but the key from our perspective is idioms of distress, idioms we express. And these idioms are part of that cultural capital that we carry with us wherever we go. We did a piece of work with Punjabi women in West London. Every woman recognized depression. They recognized symptoms. And when we said, well, what would you do? And they said, oh, what's to do? This is part of life's ups and downs. I don't want to go and see a doctor, because if I go and see a doctor, people will get to know that I'm mentally ill. Nobody would marry into my family, and I'll bring shame to the family. So what do you do? Or we'll go to the temple, we'll go to the mosque, we'll go to the church, we'll go to Gurudwara. Perfectly acceptable way of dealing with mild, moderate depression. But, and that's a big but, because we get stuck as clinicians into purely medical models. Has anybody here ever had a headache? Only 3 people. Okay. Do you mind me asking what happened when the last time you had headache? Yeah?
Last time I had a headache, I tried to tolerate it for as long as I could until I took a Tylenol.
What did you think was happening to you when you had the headache?
I was thinking about things such as maybe I haven't had enough water, or I haven't, I've been stuck in a closed room.
Right. So you had certain explanations for it, and you took action based on those explanations. And those expectations and actions are very much dictated by culture. It might be the family culture, it might be broader culture, it might be your professional culture. So what that means that people use metaphors. Punjabi women will say, my heart is sinking. A black guy will say, I feel gutted. Somebody will say, I have butterflies in my stomach. Unless you really have parasitic butterflies sitting there, it's just a feeling. So what does that mean to us is that quite often as clinicians we forget. What we are interested in are diseases, dis-ease. Patients are interested in illness. If I have this, can I go to work? Will I have enough money? Do I have a roof over my head? Will I have any relationships? When that disease of headache says, okay, I'm not going to work today. I'm going to take to my bed my partner, husband, wife, sister brings me chicken soup. This is good for you. My headache is affecting them as well at that time. That's social implications, and that's the illness bit. And one of the things about quite often across cultures, patients do not make distinction between physical health and mental health. We do. We follow this ridiculous Cartesian mind-body dualism model as if mind and body don't talk to each other. Body affects mind, affects body. And Eddie quite rightly said earlier on, we were having a conversation, that there's no health without mental health, and it's absolutely true. So we need to get out of our comfort zones and start looking at that. I've talked about institutional culture, and I'm not going to do that anymore, but I just want to focus a bit on cultural identities. What do we mean by that? At this particular point, all your identities in a way are secondary to your identity as a member of the audience. And my identity, I'm not a psychiatrist at this moment because I'm not seeing patients. I'm giving you a lecture. So my identity is a lecturer who happens to be Indian, but that's secondary. So when we talk about a migrant doctor, migrant becomes a higher degree than being a doctor. And could migrant male doctor, migrant male gay doctor, migrant male gay disabled doctor. So multiple identities start to emerge. And these, I want us to remember that if you take nothing else away from this lecture, that we all have multiple cultural identities. Cultures are defined as sociocentric, egocentric, masculine, feminine, avoiding uncertainty. And then there are linear active cultures where people do one thing at a time, concentrate on that, do it within a scheduled period. And people are generally, there's some examples of various countries there. Then there are multi-active cultures where people are really not interested in schedules. Things happen. Manana. Reality to be more important, do not like conversations unfinished, so we'll be doing 4 different things at the same time. And then there are cultures which are tight, and there are loose cultures. Loose cultures have a greater tolerance of deviance. Tight cultures are much more authoritarian, and there was a recent fascinating study which showed that tight cultures have high levels of bribery. What that tells us is that the cultures mold our behavior. What are the cultural expectations of each other? And when we talk about minorities, when we talk about racism, when we talk about homophobia, we talk about anti-Semitism, we talk about misogyny, it's all about creating the other. We create the other because it validates who we are. So my identity is not like you. So I'll find any bit which sort of confirms that. And this otherness is critical, particularly when we're looking at different groups. And that's where help seeking and accessibility to services comes in. And quite often, identities are produced through agreement, disagreement, and negotiation. So all these are some of the examples of otherism, and I've become much more interested in otherism because it's a much broader thing rather than blaming people for other things. So identity has different meanings. It's identity of the fingerprints on the gun of the killer. Identity, he or she started to doubt his own identity, who a person is, what a thing is, what are the qualities, and the sense of self. But it's also, who am I? It's also about how you see me and how I see you seeing me seeing you. So it's not as simple as saying, I am multiple things. And that is basically means that quite often we have multiple identities, individual, cultural, social, professional, and I just look at the top of the pyramid. It's a mosaic. It's a mosaic of different identities. So it depends upon where the light is shining. So light could shine on your gender, your religion, your sexual orientation, on your illness. And that is why people don't seek help, because light will shine on the fact that I'm depressed, or I have schizophrenia, or I'm anxious, or I have suicidal thoughts. These are various components of the identity: cultural, social, personal, and professional. But one of the challenges, particularly, is about racism. Wherever we go, race is an artificial category. And we created it to create the other. And racism leads to delays in help seeking. Now, one of the challenges for service providers is that you really need to treat people equitably, not equally. Now, that sort of sounds rather odd to say, but for me, equality means you give everybody sitting in this room gets a pair of shoes. Equity means that you get the shoes which fit you. And perhaps also that you get a choice whether you want high heel sandals or you want flip-flops or you want trainers. Healthcare system has to be equitable. It has to lead on that equity where people's needs, mental health needs, which are quite subtle and nuanced, how they are met. And I'm delighted to hear that Hong Kong is moving forward in terms of services for ethnic minorities, but same should apply to everybody. We should not have the need for special services for one group. Yes, they are special needs, but they should be part of the broader service delivery. And we can talk about ethnic matching and so on and so forth. But there is also institutional racism, and which is very complex and varying, and it's about power, both overt and covert power. I was going to say infects, which is probably true. It infects our attitudes. It influences our behavior. And we just make part of the problem with racism is that we make assumptions. We just make assumptions. We don't think. It's not necessarily lack of knowledge. At one level, we know, but at another, it's easy to sort of say all black people are alike. No, we are not. Not every Hong Kong person is similar to every Hong Kong person. Culture of Tsim Sha Tsui is very different from the island. And I always use this example that London is a collection of villages. Each village has its own mores, its own values, its own culture. You really need to dig in to find out what that means. Racism about differential access to services. It's about controlling, and there are, various issues. I'm not going to go through that. But what I want you to bear in mind, I'm just going to sort of bring it together in terms of treatments. Cultures see medication in very different ways. And we just assume everybody has similar values. Some cultures like very big tablets because that means there is more compound to it and therefore more likely to be successful. Some like really small tablets because that means it's concentrated and is likely to be more effective. Some cultures like injections, others like syrup, some like capsules, some like red pills, some like green pills, some like blue pills. And we never, ever, ever take that into account when patients stop taking medication. We never even ask them. And one of the fascinating things that I see every time I go to India, I've got an old classmate of mine, both literally and figuratively. He's an orthopedic surgeon. So I go to see him, we sit in his outpatient clinic. He does not do acute work, he just does chronic. And 99% of the time, when he prescribes something, the first question the patient will say, how do I take it? Do I take it with hot liquid, cold liquid, milk, tea? And the second question inevitably is, what kind of diet do I need to take with this pill? Because the concept of hot and cold is very, very important. So from his experience, he's now developed a pattern where he says, whichever seasonal vegetable is very expensive, he'll say, don't have that. Call it placebo, call it engagement. It's a way of understanding what the patient's explanatory model is. And we know that different ethnic groups have different genes, yes, and they will have different response rates to treatments. They'll respond to have different levels of antipsychotics, and people will not tell you that they may be taking other complementary medicines, whether they're Ayurvedic or Chinese or herbal or a Greek system of medicine. And those things might be interacting. So in terms of psychological interventions, and again, cultures are incredibly important. First and foremost, that most Western psychotherapies are ego-based. They're egocentric. And if you come from a sociocentric or collectivist culture, your I, who am I, is very different because you're part of a tribe, you're part of a community, you're part of a group. So part of the point that Shalini made earlier about self-harm, your self-harm means how you define yourself. And sometimes that self-harm, in particularly minority ethnic groups, is that by harming yourself, you're not really harming you. You're harming those around you. You're giving a very clear message. that I am part of you, but I'm hurting you. May not be consciously aware of it, but that is something that you need to be thinking about. Cognitive behavior therapies are by far the best in terms of this cognition. Yet, if you look at the original model on which cognitive behavior therapy was based, it says, I am a failure, the world is a dreadful place, my future is bleak. So when you say, I am a failure, that I would depend whether it's I in an egocentric way or I in a sociocentric way. So you need to modify things in those sense. And we need to look at indigenous therapies, working with religious leaders, working with spiritual leaders. How do we engage patients who may be going to talk to the priest? And we did a piece of work in London. We spent 12 evenings once a week with black church leaders, learning from them as to what they saw, processes of mental illness among black patients, but equally training them that these are the things we can do as clinicians, as professionals. These are the things which is your domain. We don't want to get into that. So to conclude this bit, I think it's fair to say nobody is an island. We are all interconnected in lots of different ways. Our identities depend upon each other. Depends upon institutions that we work in, depends upon how we brought up, where we live, where we work, where we play. And we need to, as clinicians, as therapists, we need to be sensitive to institutional cultures. But most importantly, if you're dealing with people from other culture, no matter what, culture in Hong Kong, as I said, there are different paths. But you need to understand what are the strengths and weaknesses of the person sitting in front of you. To the same degree, what are your weaknesses? Do you know your weaknesses? How are you going to deal with that? And we need to be aware of the cultural capital that we carry with us wherever we go. Part of it is to do with arts, part of it is to do with music, language, diet, etc.